Hello friends, welcome to Dentistry Updates. Today we are going to see about fabricating a surgical template for guiding sinus floor elevation in the maxillary sinus septa with simultaneous implant placement. Atrophy of the posterior maxilla, pneumatization of the maxillary sinus, and special anatomic structures often hinder implant placement because of the reduced available alveolar bone volume, a situation that can be addressed by sinus floor elevation. The presence of sinus septa may increase the incidence of sinus membrane perforation, the operation time, and the degree of surgical discomfort. The Schneiderian membrane, which lines the inner wall of the maxillary sinus, is closely attached to these septa. Furthermore, closer to the sinus septa, the membrane becomes thinner, increasing the chances of membrane perforation. Schneiderian membrane perforation has been shown to increase implant marginal bone loss as well as the incidence of acute chronic sinusitis and graft resorption. Several techniques have been introduced to reduce complications during sinus floor elevation in the presence of sinus septa. Jung reported the floating septum technique, in which the septum is mobilized by using gentle malleting with a thin and narrow osteotome, after which the membrane is carefully elevated. However, this technique was used only to address small septa. Okita reported a strategic surgical approach to deal with complex sinus septa that involved cutting and removing the sinus septa for patients who cannot undergo maxillary sinus augmentation because of a large perforation of the membrane. Dentcari reported a surgical approach that opened two windows anterior and posterior to the septa and augmented them, but the authors found it difficult to identify the position and orientation of the septa. In contrast with the principle of prosthetically guided implants, short or titled implants were selected to avoid the sinus septa, which may influence the long-term stability of the implant. Mondelaris and Rosenfeld proposed the use of computer-aided design and computer-aided manufacturing, CAD/CAM, based prototype cutting guides to precisely position the lateral wall. Osman compared the efficacy of CAD/CAM based surgical guidance with the standard lateral window approach technique in terms of reducing the incidence of membrane perforation, demonstrating that computer-guided sinus floor elevation can achieve promising results in accurately modifying lateral window osteotomy and can serve as a safe alternative to the standard technique. This article describes a modified surgical guidance template combining implant placement and the sinus lateral window approach was developed for maxillary sinus septa that could impede dental implant surgery, which may reduce complications and surgical discomfort. Import data of the patient's dentition obtained by scanning a gypsum cast into a computer-aided design and computer-aided manufacturing software program. Import images in the digital imaging and communications in medicine format. Superimpose the dentition data, maxillary jaw data, and implant-supported restoration data to form a combined data set. The sinus floor elevation guide is designed with a software program. The residual bone height in the edentulous area and the position of the sinus septa are identified. The buccal bone surface at the boundary of the lateral window area is marked, and then, two windows, anterior and posterior to the septa, 3 to 5 mm above the floor of the maxillary sinus is designed. The sinus floor elevation guide with a thickness of 2 mm throughout is completed. A 2 thick tooth supported implant placement guide is generated. The margin of the sinus floor elevation guide is extended near the alveolar ridge and the buccal area of the implant placement guide in the edentulous area connecting together as a whole. A crestal incision and a vertical releasing incision is made with a scalpel blade over the posterior maxillary ridge, and then a full mucoperiosteum flaps is elevated to provide access to the alveolar ridge and lateral maxillary regions in the edentulous area. The surgical guide as designed in the software program is positioned correctly. The outlines of the lateral sinus windows is marked with a round carbide burr. The surgical guide is removed. The osteotomy window on the lateral wall of the maxilla is made to access the sinus cavity. The Schneiderian membrane anterior and posterior to the sinus septa along the lateral, inferior, and septa walls is gently elevated. Deproteinized bovine bone mineral is placed into the sinus cavity on both sides of the septa, and the lateral windows is covered with a Resorbabel collagen membrane. An implant is guided by using the surgical guide. An implant-level impression is made 6 months after implant placement. A screw-retained crown is fabricated and placed. Surgeons once had to rely only on their experience to perform sinus floor elevation for patients with sinus septa, which often resulted in problems, as the anatomic shape, size, and height of the maxillary sinus are different among individuals. It may be difficult to accurately determine the position and size of the maxillary sinus lateral windows and whether it is even necessary to avoid the maxillary sinus septa, which often results in expanding the borders of the lateral windows and potentially increasing the incidence of sinus membrane perforation. The creation of windows on either side of the sinus septa has been a popular technique for patients in which these bony projections are present. However, the precise site of the sinus septa cannot be determined, increasing the complexity of the operation. The size of the maxillary sinus augmentation window must be expanded to ensure consistency in the location of the sinus augmentation and implant placement and to determine the position of the sinus septa, which can increase patient discomfort and the duration of the operation. An individual surgical guide with virtual pre-planning for the sinus floor elevation was combined with simultaneous implant placement in the presence of sinus septa to ensure that the implants were placed in the optimal prosthetic and anatomic location. The resulting technique provides a precise and safe approach to creating lateral windows relative to the implant site and the location of the sinus septa, improving the overall outcome of implant-supported restorations for these challenging situations.